Well, hello, everyone. My name is Larry Shulman. I'm a medical oncologist at the University of Pennsylvania, where I'm Deputy Director of the Cancer Center, and I'm a former chair of the Commission on Cancer. And today, it's my privilege and pleasure, if you will, to be interviewing Dr. Heidi Nelson, who is the Medical Director for the Cancer Programs at the American College of Surgeons, and, if you will, was my boss when I was chair of the Commission on Cancer. Dr. Nelson has a long and esteemed career as a cancer surgeon, a colorectal surgeon at the Mayo Clinic, where she was chair of the Department of Surgery, involved with the American College of Surgeons and the Commission on Cancer for many years. And in the fall of 2018, I believe it was, became the medical director for the cancer programs at the American College of Surgeons. This is all around the 100th anniversary of the Commission on Cancer, but I also wanted to spend a few minutes on the other cancer programs as well. So welcome, Dr. Nelson, and thank you for joining us today. And maybe as a first question, you had an incredible career at the Mayo Clinic. What motivated you to move from the Mayo Clinic to the American College of Surgeons and your role as medical director?
Well, first, great to be with you. Good to see you again, Dr. Shulman. We miss you in your role as chair, and I never considered myself your boss. I thought it was the other way around. The question about why medical director, I'd been working with the college for many years. I as a co-leader of the American College of Surgeons Oncology Group, ACSOG. I sat at Regents for a long time, so I got pretty familiar. I had been a cancer liaison physician at Mayo for 10 years, and of course, in and out of multiple committees in the commission and otherwise AJCC. And, I really think the mission and vision of the college and the cancer programs is so compelling that when it was time for me to give up my practice, it made total sense to shift to something else I really enjoyed, respected, and wanted to participate in. So it was an easy decision, an easy transition, and I'm delighted to be kind of in my second year, and things are going well. So it's just been a great honor.
Well, it's been wonderful for us, and I really mean that. Your presence and the many things, some of which I want to touch on, many things focused on have really transformed the way we do our work. So we're very, very grateful in that regard. And you came in at sort of a wild time. We were redoing all the standards for the Commission on Cancer, which went into effect last year. And then, of course, COVID happened, which changed all of our lives. So this was really jumping into the frying pan. But one of the things I wanted to talk to you about, from my point of view, has been one of the most important things that you've done is you don't just oversee the Commission on Cancer, you oversee all the cancer programs. And I was wondering if you could say a few words about those programs and a little bit about your vision about bringing their activities together, really integrating them more than they have been in the past. And that's been so important.
Yeah, so to tie it back to the 100-year anniversary, the vision that was set by the founders was so broad, it was such a big foundation that's why the 7 programs have grown up, is because basically they said, we want to implement new knowledge. We don't want to wait for new knowledge to come in. We want to take the knowledge that exists and make sure it's being applied consistently across cancer care. And it was even multidisciplinary back then. It wasn't all the disciplines we know now, but it was pathology, radiology, radiation therapy, and surgery. And, they demanded, that you meet as a committee, that you had tumor boards, that you documented your care, and that you kept track of patients for 5 years for end results, as well as some other things. But when you think about that, 100 years later, that's really what drives how we practice cancer care today. And as you know, as the years have gone by, more things have been added into standards, into documentation. End result 5-year data used to be captured at the hospital. But then come 1985, 1989, the National Cancer Database emerged as a centralized database, and that's generated tons of new knowledge through the PUF files and the research that can be conducted, and allows us now to transition into real-time quality reports. So all those things that were laid down as the foundation have migrated towards new products, new programs, new activities. Another example is AJCC, which really set the standard for the language of how to talk about cancer in a way so we can compare over time and across populations. The specialty groups, the National Accreditation Program for Breast Centers and the Rectal Centers, it recognizes that, we're so specialized now that you probably need other layers on top of Commission on Cancer to advance those practices as well. And then, of course, the Cancer Research Program and the new Cancer Surgery Standards Program just represent the fact that research is where new knowledge comes from, and we have that connection so that we can contribute to new knowledge generation through the standard of clinical trials enrollment that you have to fulfill, as well as when new knowledge comes out, we try to get it into practice sooner rather than later. And the tumor board video experiments have shown that that actually helps reduce that sort of 17-year time we all hear about what it takes for new knowledge to get into patient care. And we are one of the machineries capable of doing that using commission as well as other tools in the all 7 cancer programs. And you're right, COVID kind of occupies about half of what I've done so far, but in some ways, we've used the crisis to leverage new opportunities like virtual site visits. We weren't planning to do virtual site visits anytime soon, wasn't even on the list. But because of COVID, by June, we will have done 500 site visits. And people, are so adaptable. Programs are so adaptable. They're making them work. It's allowing us to continue our business and for people to, keep going and not feel like there's going to be this backlog of work. And there are, virtual meetings aren't the same. There's some things we really miss, seeing each other and having a meal and, bonding with each other, developing trust. But we still share knowledge, and the webinars we put on and the news we put out about COVID and cancer, including the one you're doing soon on vaccinations, very important. Our community has shown just by their mere attendance of thousands of people showing up for these webinars on COVID and cancer, that this has provided a very useful service. So even in a pandemic, we've been agile, adaptable, and productive, meeting customer needs, I believe.
Yeah, I would just make 2 comments about that. One is that early in the pandemic, the commission really, as you say, was agile, I think is not a strong enough expression for the fact that we pulled together our troops. We did webinars with, 48 or 72-hour notice. We had 1,000 people on each of the webinars trying to provide what guidance we could in that very critical time in March and April where we were really feeling our way. And the commission just played such an important role in you organizing us and getting us marching in the right direction and pulling this together was really incredible. The other thing that you referred to is I think the way the commission and you have, acknowledged the fact that COVID has changed our world upside down, and yet cancer care needs to go on. Cancer didn't pause because COVID was here, and we couldn't really pause our activities. We had to change some. But I think your leadership and, keeping us focused on that was really, really so important. One of the things that I think is so unique, there are a lot of groups, who talk about quality of cancer care and what we should be doing, and, and they have good hearts and the good intentions, but the commission has its tentacles in the 1,500 cancer programs around the U.S. in a way that no other organization does. And I think that puts us in a very unique position. Also gives us a unique responsibility. And I was wondering if you can talk a little bit about, how you view that. I mean, the vast majority of the cancer care in the country is linked with the commission, accredited by the commission.
Yeah, let's talk about what the commission has proven under leaders such as yourself capable of doing, changing what resources are available to patients in centers, whether it's palliative care, navigation, survivorship, genetics. When they say it's necessary to have that at your institution or have it available to your patients, that's what happens. So clearly the standards really do move care forward. It also moves quality care forward in very specific ways. So as you know from the publication on 12 lymph glands, when that became a quality measure and the hospital started getting more lymph nodes per colon cancer case, it improves survival. So in some ways, the Commission on Cancer saves lives by saying it's not enough just to do the surgery. It's important that you do it absolutely with the best skill and fidelity to get the right result for each patient, each episode of care. And that's what happens when you really implement a quality measure. And that's the power of data that we have. So there are plenty of examples of where if you're in a Commission on Cancer accredited program, you're going to do better than if you're not. But I think that brings the responsibility to the forefront, which is if 70% of the patients in the United States are getting care under Commission on Cancer accredited programs, what about the 30% who are not? And there's a very real possibility that those are communities, rural communities, safety net hospitals and the like, where they're disadvantaged. And I do feel responsible for trying to reach into those communities and do better. And we're working on that right now. We're looking at what would it take to move towards 80% of the patients in the United States, even if it's going to be a heavier and harder lift to really make sure they get the resources. What can we do on our side to make a difference for those patients who are being seen in non-CoC hospitals to really leverage our knowledge and our resources to move the needle on potential disparities. So that's on our radar right now, and we're working through that. We're trying to figure out what operational things that will take, what kind of outreach it'll take to figure out where to apply our efforts first. So I do feel responsible for making sure that our reach is beyond our current reach, but into a new reach beyond 70%, maybe 80, maybe 90% would be our aspirational goals.
So you anticipated the next question I was going to ask, which was, what do you think the major opportunities are that we can take advantage of to further improve cancer care in the country? And I think you've summarized those really well. And just again, a personal observation, and it really is reflected in your last comments, which is that you're never content with the current state. There's always work to be done. There's always something we could be doing better. I think we have accomplished an amazing amount, and your leadership has accelerated what we've been able to accomplish, but the work is never done. And there's always another opportunity. And from a personal point of view, I'm grateful for you always holding that up in front of us. We've done great, but what's next?
What's next?
What next mountain has to be climbed? So I wonder if you have any additional comments you'd like to make at the end of our interview here. You've touched on so many really critical points But your leadership is key here. And I don't know if you have anything else you'd like to share.
Well, I would say that we are always looking for the next opportunity, and it's you can't do too much too fast, because this is a large group of people. When you think about the number of volunteers and people who support these programs to ensure that patients get the best care possible, it's a very large group of people, and we have to do it in a respectful way. Change in medicine is overwhelming right now. The new drugs, the new surgical approaches, the new radiation approaches are sometimes overwhelming. And I do think it's part of our job to simplify, and where we can reduce the burden of the work so we can do more with less, is very important. We're trying to look at that from the standpoint of data abstraction. How do we simplify? How do we reduce the burden? We're looking at it from the standpoint of how can we make documentation by the provider more accurate, complete, but simpler and not duplicative of what other people are reporting. So let's focus on just what really needs to be in the record and not the extraneous things, with some flexibility. So in this world of ever increasing knowledge and fragmentation of care, because patients get care across multiple institutions, how do we coordinate better, and how do we simplify more, so it's easy to see what needs to be done today and tomorrow, and not worrying about a year from now. Another thing is we're looking at systems. In addition to looking at disparities, how can we help those hospitals that are already systems? And you and Dr. Baffa have shown that brand affiliation doesn't equate to equal quality, but the infrastructure is there. So if we can create quality programs that have system level standards and system level quality dashboards, and can really help systems figure out how to get it right for every patient who walks in one of their doors, that would be a big advance. So, as with many things, we look at all the opportunities, and we are going to move in those where the greatest benefit will occur and where we are leveraged to help. And there's many things I think we can do to help systems, and to move quality to a higher level where that's appropriate. At the same time, addressing disparities for those institutions where they're kind of on their own, and maybe they become affiliates like the University of Kentucky has, so that at least they're in some kind of a system that allows them to keep current and feel like they're well resourced, at least through some relationship that they have.
Yeah, well, thank you very much. It's hard to imagine, and I think this is actually an easy statement to make. There's no other organization in the U.S. that's been more influential in moving cancer care towards ever higher quality than the Commission on Cancer and the other cancer programs under the American College of Surgeons. And as I've mentioned, your leadership has been incredible and key in this work, and has just accelerated this in so many different directions. We're grateful for all that you've done and will continue to do. And it's ever more critical, as you say, cancer care becomes more and more complex, and the strains around all of us who are trying to provide cancer care become more stringent in the world that we live in, whether it's COVID or other issues. So thank you very much, Dr. Nelson, for your leadership, for spending the time with us today, and look forward to it continuing in the future.
Thank you for your time and for this interview, and for all your past commitments and dedication to the Commission. I'd like to thank the phenomenal staff that I had the pleasure of working with, and all of the physicians and many other groups of individuals who work with Commission. This really is a remarkable organization. I'm just delighted to be a part of it. Thank you.
Thank you.